Good afternoon to those who are here watching and anyone watching at home or from afar. I do want to take one moment to thank the veterans out there, whether you're in the audience now or elsewhere. And also for those watching elsewhere, this is our first year class in medical informatics. You will hopefully find that they're very impressive and that most of this was self-taught. So without further ado, here we go.
All right, good afternoon, everyone. Faculty, staff, and fellow students, thank you for coming. Just a quick note before we begin, we do have a handout if anyone's interested. It's referencing one of our slides about common newborn reflexes, so if anybody get that and would like it, it's available in the front with Lori. Okay? So our case today is case 35-2006, a newborn boy with hypotonia. These are the members of our group, Group 10. My name is Alex Hamidi, student Dr. Alex Hamidi, and I'll be doing the patient history and presentation today. So for our case today, we'll be discussing a two-day-old newborn boy who presented to the special care nursery unit with hypotonia. Our patient was born to his 40-year-old mother by scheduled cesarean section at 38 weeks and 6 days of gestation. This was the mother's second pregnancy, which was characterized by normal fetal movements and was generally uneventful. Rapid plasma reagent, hepatitis B, group B streptococcus, and blood type antibody screening blood tests were all negative. The mother's blood type was A positive, and she was immune to rubella. A review of the patient's family history included a 14-year-old half-sister in good health. The patient's father is functioning normally, but did have a reported history of delayed development during his infancy, which included the inability to walk until 2.5 years of age. The baby's mother had no medical problems, and there was not any additional problems, family history of neurological or muscular disease to report. The delivery of the patient was uncomplicated, but initially he had a weak cry and decreased tone in his arms. The patient's cry improved with blue eye oxygen. The patient's birth weight was approximately 8.41 pounds with a total bilirubin level of 7.2 milligrams per deciliter, indicative of mild jaundice. The patient's APGAR score was 8 at 1 minute and 9 at 5 minutes of birth. Now, a score of 10 would be indicative of a perfectly healthy newborn. And just to elaborate further on the APGAR score, Dr. Virginia APGAR invented the newborn score in 1952 to quickly summarize the health of newborn children based on 5 criteria. These criteria include appearance, pulse rate, grimace or reflex, activity or muscle tone, and respiratory effort. It was not until years later that it was made into the popular acronym used today. Upon a physical examination of the patient's first day of life, it was observed that decreased muscle tone persisted in the patient's arms and legs. 6 hours after birth, the patient had an episode of tachypnea, and the patient's oxygen saturation was 87%, below the acceptable 92% saturation level for newborns, and thus oxygen was administered. The patient was weaned off supplemental oxygen by day 2, but his hypotonia worsened and his high-pitched cry continued. He was transferred to Massachusetts General Hospital on day 2. On admission to the hospital, the patient's weight had decreased approximately 10% to 7.58 pounds. His general exam revealed that his pupils were equal, round, and reactive to light. His extraocular movements were intact, and there was no facial asymmetry or dysmorphism. The cardiac exam showed regular heart sounds with no evidence of murmurs, and the lungs were clear to auscultation. However, mild jaundice was present, as stated earlier, and there was noticeable decreased tone in his abdominal wall muscles. The patient's vital signs were normal. The patient's neurological examination showed diffuse hypotonia with no tongue fasciculations present. There was marked head lag, and the patient's extremities were in a flaccid extensor posture. Now, this is a table constructed in 1984 by Thelen, Fisher, and Ridley Johnson, which is widely considered to be the gold standard of common newborn reflexes. And we have highlighted the reflex here that were tested for on our patient. and we're going to go through them each individually. So our patient had a weak Moro's reflex, which is a response to sudden loss of support when the infant feels as if it is falling. To perform this reflex, the infant must be held horizontally on their back, and their head should be allowed to drop slightly. Now, a normal response would be for the infant to make an embracing motion by arching their back, extending their legs, and throwing out their arms. The step reflex is performed by holding the infant under their arms and allowing their bare feet to touch a flat surface. The infant should lift one foot after another in a stepping response. This reflex normally subsides by 2 months of age, and the step reflex was absent in our patient. The rooting reflex was normal in our patient and is performed by stroking the infant's cheek near the corner of their mouth. The infant should turn their head towards the side of stimulation. The sucking reflex was also normal in our patient, and this reflex is tested by placing a finger in the infant's mouth, and a normal response from the infant should be to instinctively suck the finger rhythmically. Healthy newborns should have all these reflexes intact and typically have good muscle tone and strength. They should be able to hold up their head on their own. On the patient's third day of life, or second hospital day, a neurological evaluation showed absent deep tendon reflexes in their arms, trace reflexes at the knees, and bilateral ankle clonus. Now, diagnostic testing for normal aerobic metabolism demonstrated both normal lactate and pyruvate levels. Additionally, a normal plasma acylcarnitine profile was obtained, indicative of a properly functioning fatty acid oxidation. Additional lab values demonstrated high-level liver enzyme alanine and aspartate aminotransferase levels. And most significantly, the patient's creatine kinase levels were extremely elevated, and we have highlighted there on the chart. MRI and examination of the patient exposed polymicrogyria of the medial right, temporal, and occipital lobes. Now, compared to a normal brain, polymicrogyria is a cortical malformation characterized by an excessive number of small, partly fused gyri on the surface of the brain. No other cerebral malformations were present. And just to point out the normal anatomy, this right here would be the right frontal lobe, the occipital lobe, medial, temporal. So you can notice the saw-like appearance of the gyri in front of the arrows on the right side of the brain compared to the left side where that's absent. Genetic testing was conducted during the third hospital day, and the results were characteristic of a chromosomally normal male. Chromosomal testing for Prader-Willi syndrome and Angelman syndromes was conducted and will be discussed further within our differential diagnosis. On the third day at the hospital, the patient was breathing normally, but oral feeding resulted in choking, oxygen desaturation, and bradycardia. Now, these symptoms resolved when the bottle was removed and the patient was held upright. Subsequent feedings were given via gavage, which is insertion of a tube orogastrically through the mouth into the stomach. Speech pathologists discovered choking and coughing during the pharyngeal stage of swallowing in their evaluation of the patient's fifth day in the hospital. A barium swallow resulted in aspiration of a small amount of barium into the upper trachea, but there's no evidence of abnormal communication between the esophagus and trachea. It was then recommended that the patient be fed by gavage from that period forward. A nerve conduction study was performed showing normal right medial sensory and tibial motor responses. Needle electromyography was conducted in the right deltoid, rectus femoris, and tibialis anterior muscles, and fibrillation potentials with myopathic units were found. Normal muscle should be electrically silent, and fibrillation potentials are indicative of membrane instability. The following day, the patient's weight was measured, and it was found that it had increased to 8.34 pounds, which demonstrated success in feeding the patient via gavage. A final muscle biopsy diagnostic test was performed, which we will discuss further in our differential diagnosis. The patient remained at the hospital until he reached 8 weeks of age, where he was then transferred to a rehabilitation facility. And to discuss the differential diagnosis, I may present to you student Dr. Nilesh Gupta.
Thank you, student. Hello? Can you hear me? Okay. Thank you, student Dr. Alex Hamidi. My name is student Dr. Nilesh Gupta, and I'll be discussing the differential diagnosis for case 35-2006. Due to the variety of causes that could lead to hypotonia, it is useful to categorize the possible diagnoses into the 4 categories presented, from the center to the periphery as it pertains to the muscle itself. So we have the central nervous system, peripheral nervous system, the neuromuscular junction, and the muscle itself. The potential diagnoses presented represent the most probable and most likely causes of our patient's symptoms and is not indicative of the amount of diseases that could be present within each category. Because central and peripheral nervous system disorders typically do not present with elevated serum creatine kinase levels, we can generally rule these out from our possible diagnoses. Prader-Willi syndrome specifically is characterized by poor intrauterine movement, acromicria or small hands and feet, developmental delay, and almond-shaped eyes, none of which were present in our patient. Further, the chromosomal analysis performed on the 3rd hospital day confirmed this diagnosis to be improbable. In the peripheral nervous system, spinal muscular atrophy type 1 causes flaccid weakness with diffuse fibrillations in infants. However, this is unlikely because there is an absence of tongue fasciculations and areflexia that usually accompany this disorder. Patients with sensory neuropathy commonly present with sensory deficits which were not observed in our patient, and the normal conduction velocities in our patient are inconsistent with the conduction velocities observed in those with demyelinating peripheral neuropathy. As we move to the neuromuscular junction, we first come across infantile botulism. This is caused by bacteria typically within soil and dust, and honey can also contain bacteria that could cause botulism. Yet there is no history suggesting an exposure to food that could cause infantile botulism in our patient, and the hypotonic symptoms would have been delayed rather than at birth if our patient had infantile botulism. Furthermore, our patient presented with a normal pupillary reactivity that is typically abnormal in botulism patients. Infantile myasthenia gravis is passively acquired through maternal antibodies. Thus, if our patient had said disorder, the mother should have also presented with symptoms of myasthenia gravis. Since the mother lacks this disease, it is unlikely our patient presents with this disorder. Patients with protein alterations in the presynaptic and postsynaptic junctional apparatuses present with profound ptosis, normal creatine kinase levels. Since our patient has elevated creatine kinase levels and no visible signs of ptosis, this diagnosis can most likely be ruled out. The majority of the previous diagnoses were ruled out due to the elevated serum creatine kinase levels our patient presented with. It is important to note that serum creatine kinase is a biomarker for muscle damage and is indicative of defects or problems with the muscle proper and not anything in the premusculature. This leads us to believe that the patient's diagnosis is a type of congenital abnormality of the skeletal muscle. And there are 3 skeletal muscle abnormalities we considered. The first is neonatal myotonic dystrophy with floppiness. This is a dominant mutation disorder where the baby is more prone to hypotonicity if the mother has had this disease. And while the mother could have had undiagnosed myotonic dystrophy, the lack of the family history of this disease allows us to rule this diagnosis out. Congenital myopathies can either be autosomal dominant or autosomal recessive, and they present with distinct histologic abnormalities and high-arched palates or abnormally arched feet, none of which were present in our patient. Additionally, congenital myopathies do not typically have elevated creatine kinase levels. Congenital muscular dystrophy presents with clinically significant muscle weaknesses at birth, elevated serum creatine kinase levels, and histologic features of dystrophy on the muscle biopsy. There is also abnormal nervous system development. There are 3 major congenital muscular dystrophies we considered. The first is Duchenne's muscular dystrophy. This is an absence in the submembrane protein dystrophin that connects 2 complexes of transmembrane proteins together. This is clinically evident 6 to 9 months after birth and is a relatively rare disorder, thus not a major consideration. For congenital muscular dystrophies with markedly abnormal CNS development, there existed 3 major potential disorders. The first is Fukuyama-type congenital muscular dystrophy. This is an autosomal recessive mutation in the fukutin gene, and patients can present with severe mental retardation, seizures, and progressive hydrocephalus. Immunohistochemical staining would show greatly reduced surface membrane alpha-dystroglycan and reduced laminin alpha-2. Ocular lesions like myopia, retinal detachment, and optic nerve atrophy may accompany this disorder, and there is moderately elevated serum creatine kinase levels. The pathology for Fukuyama-type congenital muscular dystrophy is lyssencephaly type 2, pachygyria, and cerebellar lesions. The second is muscle-eye-brain disease. This is an autosomal recessive disorder caused by mutations in O-linked mannose beta 1,2-N acetylglucosaminal transferase. The immunohistochemical staining would show increased alpha-dystroglycan and increased laminin beta 2. Patients would present with severe mental retardation and eye malformations including severe myopia, glaucoma, and cataracts. The pathology for muscle-eye-brain disease is the disorganization of the cerebral cortex without horizontal lamination or cobblestoning, hydrocephalus, and cerebral hypoplasia with an absent inferior vermis. The third is Walker-Warburg syndrome. This is a recessive inheritance mutation of O-mannose transferase 1, and immunohistochemical staining would show reduced beta-dystroglycan and normal myrisin staining patterns. Serum creatine kinase may present as normal, and this disorder is usually lethal within the first years of life and can present with severe mental retardation, seizures, cataracts, and microphthalmos. Pathology for Walker-Warburg syndrome includes lysencephaly type 2, pachygyria, hydrocephalus, occipital anencephaly, and brainstem and cerebellar lesions. However, all these diagnoses can be ruled out because they present with other structural brain defects not present in our patient. Remember, our patient only presented with a brain abnormality of the polymicrogyria. So, congenital muscular dystrophy with minimally abnormal CNS development is the most likely diagnosis, and there are two categories we considered: normal myrisin levels and myrisin deficient. Myrisin itself, or the laminin 2 protein, is a trimeric protein with 3 subunits: alpha 2, beta 1, and gamma 1. They present in skeletal muscle, cardiac muscle, skin, brain, and the peripheral nerves, and they help maintain the stability of the relationship between the cell membrane and the extracellular matrix. With congenital muscular dystrophy with normal myrisin levels, they typically present with a mutation affecting the gene that anchors skeletal muscle to myrisin, such as collagen or the integrin receptor for myrisin in the cell membrane. However, our patient presents with more severe active myonecrosis and more elevated serum creatine kinase levels than what congenital muscular dystrophy with normal myrisin levels would present with. So, our most probable diagnosis is congenital muscular dystrophy with deficient myrisin levels. This is a mutation in the LAMA2 gene causing a reduction in the myrisin alpha-2 subunit. In addition to myrisin's structural capabilities, it also enhances the formation of myelin by oligodendrocytes. Thus, a deficiency in myrisin can lead to a decrease of myelin within the brain. Myrisin deficiency via LAMA2 mutations has also been associated with the disruption of the blood-brain barrier, resulting in an increased water content indicated by the abnormally bright signal in the white matter of our patient's T2-weighted MRI image. Central nervous system abnormalities, including but not limited to mental retardation, epilepsy, and abnormalities of gyration, such as the polymicrogyria in our patient, have also been known to accompany this disorder. And while there is primary or secondary myrisin deficiencies, it is unknown what our patient is presenting with. A diagnostic muscle biopsy test was performed to confirm our differential. Immunohistochemical staining with anti-myrisin antibody was done to detect the levels of myrisin within the muscle. The top left indicates the muscle biopsy of our patient, while the bottom right is the myrisin control stain. Note that the anti-myrisin antibody binding to myrisin in the extracellular matrix in the bottom right image indicates normal myrisin levels. However, in the top left image, there are free-floating anti-myrisin antibodies that are unable to bind to any myrisin in the extracellular matrix, indicating a myrisin deficient biopsy. Anti-dystrophin antibody immunohistochemical analysis of dystrophin was also performed to confirm that there is an appropriate dystrophin expression, ruling out all dystrophin-related disorders. Therefore, our final diagnosis for case 35-2006 is congenital muscular dystrophy caused by severe myrisin deficiency. And now I'd like to introduce student Dr. Mladen Grigorov to discuss treatment and emerging research.
Good afternoon. My name is student Dr. Mladen Grigorov, and I'll be addressing the treatments, emerging research, and ethical and legal considerations having to do with our case. As we saw, our differentials led us to the diagnosis of myrisin-deficient congenital muscular dystrophy, and here are some facts on the disease. It is an autosomal recessive disease with an incidence of 0.7 out of 100,000 in the United States. So it's not a very prevalent disease. But although it's not a very prevalent problem, it is a very expensive problem to take care of. A study in 2013 citing that it costs approximately $51,000 a year to take care of an individual with this disease. And the symptoms include muscle weakness, breathing problems, and feeding problems. So how are we going to treat these symptoms? Well, for the breathing problem, we performed a tracheostomy. For the feeding problem, we performed a gastrostomy. And for the muscle weakness, regular physical therapy appointments will be performed over the course of this patient's entire life. Now you might be wondering, what exactly is a tracheostomy and a gastrostomy? A tracheostomy is a surgical procedure in which an incision is made into the neck in order to access the larynx. Through this incision, a trach tube is placed, and this provides an alternative passageway into the lungs, and this solves the patient's breathing trouble. Now, although this solves the patient's breathing trouble, there are complications that can arise from this. This is due to the fact that the nasal canal, we are bypassing the nasal canal, and by bypassing the nasal canal, we cannot develop positive epiglottic pressures. Positive epiglottic pressures are needed in order to develop a cough mechanism. Without this cough mechanism, extra secretions that are accumulating in the throat are going to drip down into the lungs, and recurrent infections are going to occur, as was the case with our patient who had numerous pneumonia infections after being discharged. Now, in order to solve the feeding trouble, we performed a gastrostomy. And this is a similar procedure, except an incision is made into the abdomen, and the G-tube is placed directly into the stomach. This allows nutrition to directly be administered into the stomach and solve the patient's feeding trouble. For the muscle weakness, this will be something that will be needed to be addressed over the course of the patient's entire life, and physical therapy will address this. Regular physical therapy appointments will be needed to be made and upheld throughout the patient's life, and this will include passive stretching, active exercise, water therapy, and monitoring the muscle wasting over time to make sure it's proceeding at the most minimal rate possible. Remember that due to the fact that this patient is not able to utilize his muscles, they're going to waste away, and we want to inhibit this process from occurring due to the fact that this can lead to early death for a patient if this is not being minimalized. We also want to share with you all today that osteopathic manipulative medicine has a place in this case. This is due to the fact that the musculoskeletal system plays a vital role in moving lymph back sent to the central core of the body at the thoracic duct. And osteopathic manipulative medicine lymphatic treatments can help aid in this diminished musculoskeletal system's activity. And we want to share with you all today that there's 3 techniques that are easily taught to family members and can be easily performed to patients suffering from the disease. These are the rib raises, tapotement, and pedal pump. The rib raises is a treatment in which an individual goes to the side of the patient's body and contacts the ipsilateral or same side of their ribs with the tip of their fingers, creates a fulcrum with their hands. They then provide an anterior force to these ribs, and this in turn stimulates the sympathetic chain ganglia and can aid in moving lymph back to the central core at the thoracic duct. The tapotement is a percussing motion in which the patient is laying on his stomach and a physician is providing a percussing force up and down the patient's back. This in turn breaks up consolidated material that are draining down into the lungs and also aids in moving lymph back to the central duct, to the thoracic duct. And finally, the pedal pump. This is done in which a physician goes down to the patient's feet and contacts the plantar portion of their feet. They then provide a rocking motion back and forth at a rate of 110 to 120 oscillations per minute. In turn, this creates an oscillatory pump through the patient's body and can aid in moving lymph as well back centrally. All of these, it's very important to remember, before you start these procedures, an individual needs to open the thoracic duct, and then when he's finished performing the procedure, he needs to close the thoracic duct as well. Now let's address what the scientific world is doing to try and find a cure for this problem. There are currently numerous research projects in numerous areas undergoing to try and find a cure. These are in gene therapy, protein therapy, apoptosis inhibition, and decreasing fibrosis. We have listed some of the most promising research projects and their authors right below them. Phosphorodiamidate morpholino oligomer is a gene that is shown that if you insert it into the muscle and activate it, it improves some muscle function, as well as mini-agrin gene. It is also shown that if you put it in the muscle, stimulate it, it also will restore some muscle function. For protein therapy, laminin 111 has shown to be a very good substitute for the laminin alpha-2 deficient individuals. Whenever they put this protein in, it substitutes itself and restores some muscle function as well. Apoptosis inhibition is done by 2 pills that can be administered, a megapill, minocycline, and doxycycline. This is because due to the fact that muscle is wasting, apoptosis is occurring, and by administering these pills, we can decrease apoptosis from occurring and help try and minimize the muscle wasting in the patient. And finally, decreasing fibrosis. Many of you all may know that losartan has its effects in hypertension, but it also has effects, as shown, in decreasing fibrosis. Again, due to the fact that the muscle is wasting, apoptosis is occurring, and a result, fibrosis is occurring. And this pill helps minimize that fibrosis from happening. There are also a number of ethical and legal considerations that have to do with our case. These are with quality of life, patient autonomy, and resource allocation. For quality of life, we know that our patients can be wheelchair bound and have to live with permanent tubes for the rest of their life, and it's very costly to take care of them. And many individuals may think, well, why are we spending all this money for an incurable disease? But these individuals are able to develop very well cognitively and be able to live rich and fulfilling lives. So it's very important that we do provide the best healthcare we can to these people. For patient autonomy, many of the decisions that will be made for this patient due to the fact that it is a child will be done by the parents. And this patient will have to live with these decisions for the rest of his life. And this directly inhibits his patient autonomy due to the fact that the parents are making the decisions for him. And finally, resource allocation. It is a very expensive disease to take care of. It is incurable, and lifelong support will be needed. And there are many diseases out there that are curable and are a lot less expensive, and the money might be able to be used more effectively into treating. So it leaves the question of if the resources are being allocated as effectively as they possibly could be. We wanted to share some information with y'all on where to get education about this on this project, and this is through musculardystrophy-association.org, familydoctor.org, and Clinical Key. These sites have very good handouts on how to educate yourself on the problem. In conclusion, due to the fact that this disease does not have a cure out for it, we wanted to stress that support is the most important thing that an individual can do and a physician can provide. Support in numerous ways, whether it be financial. Again, we saw it's very expensive to take care of this problem, and families will need ways to find how to find this financial support. Physicians can provide information on where to go and where to find this financial support. Physical therapy. It will be very important for physicians to make sure that there are regular physical therapy appointments set up and the patients and family members are upholding these physical therapy appointments. And finally, family counseling. These families are going to live with a child that will not be able to partake in normal activities many of us might be able to partake in. And because of that, this is going to take a stress on their marriage, and does take a stress on their marriage. And it's very important for a physician to try and provide counseling or try and provide information on where to get counseling for these problems these families will be facing. Remember, as osteopathic physicians, we are not only treating the disease, but we are treating the patient as a whole. We would like to thank the individuals that helped with this project. We'd also like to thank you all for joining us today. We now open the floor for questions.
Great job. Let's start over here with some questions.
Our first question is, why would a baby get bradycardia with choking and or feeding difficulty? Well, this can occur when the vagus nerve sends a signal to the heart that suddenly drops the heart rate. So choking or gagging can trigger this response, which is called the vasovagal reflex.
Another question we received was, what is the prognosis of your patient? So about the lifespan, and it's about 20 to 30 years.
The next question is, what does gavage mean? So gavage just means anytime you administer food or drugs forcibly. In our case, it's because our baby can't suck and swallow properly. So in order to deliver nutrients, we had to do an orogastric tube, which is a tube that goes in through the oral cavity and into the stomach to deliver formula milk.
Okay. This question is, what is the cause of the stepping reflex and why is it diminished at 2 months? So the stepping reflex is one of the primitive reflexes of a newborn. You hold it up by its arms, and if its feet are on a flat surface, it'll kind of start to dance. These start to diminish during normal development just due to the normal growth of the frontal lobe. If they don't diminish, then that can be a sign of some sort of trauma or some developmental delay.
Okay. And then the question that I have is, an MRI takes a while to do. How were the physicians able to keep the infant's head from moving to get the images? That's a great question. So I checked out the U.S. National Library of Medicine, and apparently there are some standards for this, some protocols that they follow. For a patient such as ours that's under 2 months old, they'll typically wait till after the baby's done feeding, and then it's going to fall asleep. So they try to pick a point where baby's easy enough to handle. They also will wrap the baby to keep it warm, to help keep it calm. And they also use headphones just to prevent the noise from waking the child up. And then they'll also put pillows or like a foam form to help stabilize everything. But yeah.
Is it contraindicated to sedate the child at this age?
No. There are special nurses, or there are nurses that have special training for that. And so if for some reason they can't get the child to calm down, if they're not sleeping, for whatever reason, they can sedate the child. And yeah, there are certain standards and specialists that do that.
Okay, great job. I'd like to open it up to any faculty that may have any comments or further learning points. All right.
I thought that was excellent. One of the things with these special needs kids when they're younger, as they get older, that are complicated. One of the things to remember is that care coordination is one of the most important things a physician can do. Looking at what's going on at home, what the family situation is, what their resources are, how can we help them? And at an osteopathic institution, we kind of promise the world that you guys are going to be better at that kind of thing. So make it your goal to live up to what we're promising the world. But no, you guys are particularly well suited to take care of special needs kids. Looking at the whole patient, looking at the whole person, looking at the whole situation. So just keep that in mind, because sometimes people don't like to take care of special needs kids, but it can be one of the most rewarding things you do as a physician. So, but good job, guys.
Anybody else? Okay. Well, thank you so much for attending, and great job, guys.